Hello, good morning everyone. This is Dr. Elackiya, Assistant Professor in the Department of General Medicine in Mahatma Gandhi Medical College, Pondicherry, India. We are going to deal with a case report, a common fever with an uncommon presentation, that is dengue fever presenting with fulminant myocarditis. Before going into the case report proper, just we'll have a brief outline, that is introduction, case report, literature review, discussion and conclusion. Dengue is a worldwide condition spread throughout the tropical and subtropical zones. It is a highly prevalent arthropod-borne viral disease. It is transmitted by Aedes aegypti and Aedes albopicticus. There are 5 serotypes: DENV1, DENV2, DENV3, DENV4 and DENV5. Of these, DENV2 is associated with the unusual manifestation of dengue like myocarditis. Incidence of dengue has increased significantly in the last several decades. According to WHO, there are between 100 and 400 million new infections every year. Coming to the classification of dengue, it's very much simplified. It's either dengue or severe dengue. So in dengue, it is with warning signs or without warning signs. First, we'll see the features which comes under without warning signs. It is either fever with any one of the following features such as nausea, rash, aches and pains, leukopenia, positive tourniquet test, laboratorily confirmed dengue, whether the patient is able to tolerate adequate oral volumes of adequate fluid replacement, able to pass urine at least once every 6 hours. When it comes to dengue with warning signs, it includes persistent vomiting or abdomen pain, lethargy or restlessness, then bleeding manifestations, mucosal bleed, increase in hematocrit with concurrent decrease in platelet count, liver span more than 2 cm, that is liver enlargement more than 2 cm, and any one of the comorbid conditions such as pregnancy, infancy, old age, diabetes mellitus and renal failure. Now, dealing with severe dengue, we have 3 types: severe plasma leakage causing shock, fluid accumulation leading to respiratory distress, severe hemorrhage, and third one is severe organ impairment. Discussing about the atypical manifestations of dengue includes the Guillain-Barré syndrome, fulminant myocarditis, acute lung injury and rhabdomyolysis. So our topic proper is dengue fever causing fulminant myocarditis. So we should know what are all the common cardiac manifestations in a dengue fever. They include atrioventricular block, sinus node dysfunction, pericardial effusion, ectopic ventricular beats, myocarditis and atrial fibrillation. Myocarditis, it is a serious underdiagnosed condition affecting people of all ages. Myocarditis, it is an inflammatory condition of myocardium. Coming into the causes of myocarditis, they include infective, autoimmune, autoreactive and toxic myocarditis. Infective causes include bacterial, viral, protozoal and helminth. Autoimmune, the causes are SLE, sarcoidosis, thyrotoxicosis, diabetes mellitus and inflammatory bowel disease. Autoreactive myocarditis, we have lymphocytic myocarditis and giant cell myocarditis. Toxic myocarditis, examples are amphetamine, cocaine, radiotherapy and chemotherapy. Types of myocarditis, a classification we have based on the duration and also the histopathological classification. First, we will discuss about the types of myocarditis based on the duration. It is acute, subacute, chronic and finally the fulminant. Acute myocarditis, if the duration of symptom onset and diagnosis is less than 1 month, it is acute myocarditis. Subacute, if the duration is 1 to 3 months, it is subacute myocarditis. Chronic myocarditis, if the duration is prolonged, if it is more than 3 months, it comes under chronic myocarditis. About fulminant myocarditis, we will discuss in next slide. Histopathological classification, It can be myocarditis can also be classified based on the type of cellular infiltrates, whether there is presence or absence of cardiac myocyte injury. They include lymphocytic, eosinophilic, giant cell myocarditis and granulomatous myocarditis. Lymphocytic myocarditis, it is associated with radiation exposure, toxins, drugs. Eosinophilic myocarditis, it is an uncommon form of myocarditis associated with parasitic infections and hypersensitivity reactions. Giant cell myocarditis, it is idiopathic in nature, but most often it is associated with some autoimmune disorders. Granulomatous myocarditis, it is associated with sarcoidosis. So coming into the topic proper, we are going to deal with fulminant myocarditis. Fulminant myocarditis is a severe, rapidly evolving form of acute myocarditis with associated cardiogenic shock requiring inotropes or mechanical circulatory support. Our case report is dealing with dengue fever complicated with acute myocarditis. We are going to report a rare case of dengue fever complicated with acute myocarditis. Optimal pharmacological management had a successful outcome. A 46-year-old female with no comorbid illness presented to a hospital with complaints of fever and myalgia. Her total count was 2500 cells per centimeter cube and platelet count was 49,000 cells per centimeter cube. She was admitted with a provisional diagnosis of tropical fever syndrome and necessary investigations were sent. NS1 and IgM ELISA for dengue turned out to be positive. She was treated with supportive measures. On day 2, patient developed retrosternal chest pain and breathlessness and symptoms of pulmonary edema. Here you can see the ECG of this patient showing ST depression and T-wave inversion over the precordial leads V4 to V6, lead 1, lead 2, AVL and AVF. Since patient had breathlessness, chest X-ray was taken which showed features of pulmonary edema. As patient had dynamic changes in ECG, cardiac enzymes were sent and the values were found to be elevated. Serum troponin was 2830 nanogram per ml. Patient was proceeded with echocardiogram which showed a global hypokinesia of left ventricle with regional variation, ejection fraction of 30%, it is severe LV systolic dysfunction. Patient was diagnosed as myocarditis based on the history and ECG findings. Patient became hemodynamically unstable and breathlessness worsened. So she was intubated and treated with noradrenaline infusion. Following day, patient deteriorated hemodynamically and required second inotrope, that is dobutamine. The patient gradually improved after 5 days and we weaned off from inotropes. On day 10, we proceeded with coronary angiogram and it showed normal coronaries. Day 12, cardiac MRI was done which showed faint enhancement in mid-myocardium consistent with myocarditis. Since patient was hemodynamically stable and symptomatically better, patient was discharged. We followed up the patient after 2 weeks. Follow-up echocardiogram after 2 weeks showed normal left ventricular function, ejection fraction of 60% with no regional wall motion abnormalities. This is the cardiac MRI of the patient. Early enhancement indicates hyperemia and late enhancement indicates necrosis. The arrow pointed out shows delayed post-contrast images suggestive of myocardial fibrosis or necrosis. There was a faint enhancement in mid-myocardium in nearly all left ventricular segments, more so in mid-cavity level, consistent with resolving myocarditis. Coming into the literature review, we searched the PubMed database for articles published about dengue fever and fulminant myocarditis between the year 2000 and 2023. The information retrieved includes author, year of publication, gender, age, comorbid conditions, ejection fraction, angiogram, cardiac MRI, myocardial biopsy, dengue serotype, outcome and treatment. So, if we see the study published by Leck et al. In the year 2008, a 25-year-old male with no comorbid illness died in spite of receiving the advanced treatment modality left ventricular assist device support. In the year 2013, Miranda et al. Published a study which shows that a 37-year-old female previously diagnosed as Alport syndrome presented with features of myocarditis, and the patient died after receiving mechanical ventilation. And in the study done by Yush et al. In the year 2014, a 57-year-old female with a comorbid of hypertension survived after receiving ECMO. Study done by Q et al. In the year 2016, a 52-year female with no comorbid conditions died after receiving the advanced treatment modality ECMO. The 10th study comes about our case of 47-year-old female with no comorbid illness diagnosed as fulminant myocarditis, and our patient survived with inotropes and mechanical ventilation. To put it in a nutshell, there have been only 14 cases of fulminant myocarditis reported so far in PubMed between 2000 and 2023. Risk factors included old age, type 2 diabetes mellitus, hypertension and asthma. Of the 14 patients reported, only 5 survived despite providing newer treatment modalities like intra-aortic balloon pump and extracorporeal membrane oxygenation. As I have mentioned earlier, we have 5 serotypes of dengue, and among these it is only DNV2 which is associated with the unusual complication of dengue like myocarditis. If we come back to the slides where we have done the literature review, so we don't have data for dengue serotype in most of our cases. We have the dengue serotype in only 2 studies. One is the study conducted by Marcus N et al. In the year 2013. So the dengue serotype is DNV2. Year 2015, a study done by Ramanathan and co. Here also we can find the dengue serotype is DNV2. So for other cases, we don't have any records related to dengue serotype. So we are also having evidence that DNV2 is associated with the unusual manifestation of dengue like myocarditis. Coming to the discussion part, criteria to diagnose fulminant myocarditis is rapid onset of symptoms of heart failure within 2 weeks of an inciting event, prodromal symptoms of upper respiratory or gastrointestinal viral infection, rapid hemodynamic instability requiring a large dose of inotropes, CMR or EMB proven myocarditis, exclusion of other cardiac diseases like coronary artery disease. So the diagnosis is mainly based on ECG findings, echocardiogram, cardiac magnetic resonance imaging and endomyocardial biopsy. Gold standard will be endomyocardial biopsy. So treatment part, it is usually supportive measures with the aim of management of any associated complications such as arrhythmias or heart failure, and even some patients may require intensive care unit admission. If patients have presented with hemodynamic instability or fulminant myocarditis, they require inotropic agents or any other modalities like extracorporeal membrane oxygenation. So first, inotropic agents, they are the first line to enhance the cardiac pumping function. If there is no response, then we'll go to intra-aortic balloon pump or extracorporeal membrane oxygenation. If the patient is refractory to these treatment, then the last modality will be cardiac transplantation or a left ventricular assist device support. Conclusion: fulminant myocarditis, it is one of the rare entities of myocarditis which is associated with a rapid downhill course if not recognized early and treated promptly. Early recognition of fulminant myocarditis is crucial as recovery to near normal cardiac function can occur during aggressive circulatory support. There is also emerging evidence for the use of selective immunosuppressive therapy in chronic myocarditis patients, but still results are under debate. We present this case for its rare entity and fulminant presentation, which improved with supportive management because of timely diagnosis. Thank you.